students, let's talk about the skeletal system. So the skeleton is a supporting framework, and as far as anatomy goes, the skeletal system is fairly straightforward. It's a little bit difficult because all of the bones and all the bumps on the bones have their own little names, but there's no conceptual difficulty in this. It's just kind of brute memorization. On the other hand, physiologically, the skeleton has a completely different function. So the skeleton is living tissue. And that seems a little weird to most people because when you go to the doctor's office and you see the skeleton in the corner, it better be dead, right? But inside of you, your skeleton is very much alive. It repairs itself. If it was dead, it would not repair itself. We're going to start off talking about cartilage to talk about the skeletal system. So when we look at cartilage in an adult and cartilage in a child, children have a little bit more cartilage because their bones are still developing. We're going to make a cartilage model and then replace some of that cartilage with bone. So bones perform several basic functions: support and protection. For instance, your rib cage protects your thoracic organs, your heart and your liver and your lungs. Bones allow for movement. We use our bones for hematopoiesis, which is making new blood cells, and we use bones to store minerals and energy. As I mentioned, bones provide protection. The rib cage, the cranial bones protect the brain, the vertebrae protect the spinal cord, and the pelvis protects the urinary and reproductive organs. Bones help move us around because they supply attachment sites for muscles. They act as a system of levers. Hematopoiesis means the creation of new blood cells, and this is for both red and white blood cells. And finally, bones are used to store minerals and energy. Calcium is supercritical for muscular contraction, for blood clotting, and for the transmission of nervous impulses. If you don't have your calcium balance right, then you're going to probably die quickly and painfully. Let's look at the shape of bones for a moment. There's 4 classifications of shape. There are long bones, which are longer than they are wide; short bones, which are approximately as long as they are wide; flat bones, which are flat; and irregular bones, which are kind of the junk drawer of bone classification. They don't really fit into any of the other categories. Now, long bones are longer than they are wide. They're elongated. They have a central shaft called the diaphysis, and it's the most common bone shape we have. And they vary in size. The femur, of course, would be a long bone, but even the small distal phalange in your 5th digit, the last bone in your pinky finger, is a long bone. So look at a newborn infant. Look at their little tiny toe, their little pinky toe. There are 3 bones, 3 long bones in that toe. Some examples of short bones would be carpal bones, or the tarsal bones of the foot, or the sesamoid bones. For example, the patella, your kneecap, is a sesamoid bone. Flat bones are used all over the place. The ribs are flat bones. The bones of the skull, some of the bones of the skull, I should clarify, are flat bones. Your shoulder blades, the sternum. And then finally, the irregular bones, things like the vertebra, the hip bones, and some of the bones in the skull are irregular. Now let's zoom in on look at a long bone. Remember, the diaphysis is the long central cylindrical shaft of the bone. It provides leverage, it supports weight, and it's made mostly of compact bone. So compact bone is very dense and very strong. The inside of the diaphysis is hollow. This is called the medullary cavity. Remember, medulla means middle, so this the cavity in the center of the cylinder, and it contains marrow. In children, it contains red marrow, which is useful for hematopoiesis, and in adults, it contains yellow marrow, which is energy storage. Then when we look at the ends of a long bone, both the proximal and the distal ends, we call those ends an epiphysis. Now, the epiphysis has a different structure than the cylindrical diaphysis. The epiphysis has a kind of outer shell of compact bone, and then the inside is what we call spongy bone. Now, spongy bone is not soft like a sponge. It just looks like a sponge. It's almost like coral. It's very, very hard, but there's a lot of passageways and air holes in it. The epiphysis is where we are going to find our articular cartilage. It covers the surface of a joint, helps reduce friction in the joint, and is useful for a little bit of shock absorption. Now, the metaphysis is kind of the region between the diaphysis and the epiphysis. And in the metaphyseal region, we will have what is called an epiphyseal plate. Now, the plate is an area of cartilage in children that is continuing to grow. And in adults, this area has turned into bone and is called an epiphyseal line. It's the remnant of the epiphyseal plate, and it no longer grows. So here's an example of our humerus. We have our articular cartilage on our proximal end and our distal end. We've got our main diaphyseal shaft. We've got our two epiphyses. And then we've got this metaphysis region here. So this is our distal metaphysis, and we also have a proximal metaphysis. You can see our central diaphyseal cylinder made out of our compact bone with our medullary cavity inside. Remember, that's not hollow, it's filled with some kind of marrow. And then when we get to the epiphysis, we're going to have that hard cap or layer of compact bone, also known as cortical bone. And then we're going to have the spongy bone in the middle. Now, on the very outside of bone, we've got a tough outer sheath of membrane called the periosteum. Peri means around, and osteo is bone, so this is the tissue that goes around the bone. It's very tough, fibrous, irregular connective tissue. It helps protect the bone, it helps to anchor blood vessels, and is an attachment site for ligaments and tendons. And the periosteum is firmly attached to bone through microscopic fibers called perforating fibers, or also known as Sharpie's fibers. Here's an example. We've zoomed in a bit. You can see the fibrous layer of the periosteum, and then we've got our active cellular layer where we're going to have more of the fibroblasts. Here's our perforating fibers. These are all small collagenous ligaments that help to anchor the periosteum to the actual osseous bone. On the inside of bone, we also have a membrane. This is called the endosteum. Endo means within, so it's inside the bone. It covers all the internal surfaces of bone inside of the medullary cavity, but it's incomplete. It's kind of half there, half not. And it contains osteoprogenitor cells, osteoblasts, and osteoclasts. Here's an example of our endosteal membrane along some of that spongy bone in what we call the trabecula. If we look at short, flat, and irregular bones, they're a bit different from our long bones. They have an external surface of compact bone and an interior surface of spongy bone. That interior surface in the flat bones is called diplo. There is no medullary cavity within our short, flat, and irregular bones. Here's a great example. We have our periosteum here, our layer of cortical bone, our layer of spongy bone that would be covered with our endosteal membrane, another layer of cortical bone, and then another layer of periosteum. Here's a little zoom in of the spongy bone. You can see it looks like a sponge, but it is hard. It's all calcified. And the patterns that we see of growth inside the spongy bone are called trabecula. Now, bones have a huge blood supply. Bone is highly vascular. In fact, some of the holes that blood vessels need to get into bone are so big you can see them on X-ray. Those are called nutrient foramina. Nerves also supply bone. If you've ever broken a bone, you can attest to that. Now, because bones have a huge blood supply, it's very easy to bring in repair elements and fix the bone. So, for example, if you break a bone, in about 6 to 8 weeks, you've pretty much healed it up again. If you've ever stretched a ligament or a tendon, you know that's not the case. Ligaments and tendons have a terrible blood supply. It's awful, and it takes them forever to heal. Hyaline cartilage is avascular, and it doesn't have any blood going to it. Instead, it gets its nutrients through diffusion, which takes a long, long time. And so once cartilage is damaged, it pretty much never gets better. As we look at our bone marrow, I mentioned we have a red bone marrow, which is hemopoietic. It is where we form our red and white blood cells. Children have a lot of red bone marrow because they're making lots of new blood cells all the time. In adults, this tends to go away, and a lot of it is replaced with yellow marrow, and the red marrow is kind of sequestered in areas like the skull, the vertebra, the ribs, and the heads of the long bones, such as the femur and the humerus. The yellow bone marrow is basically just fat. Nice picture of red bone marrow, a little bit of yellow there in the center. Bone marrow transplants are interesting. Because bone marrow is where white blood cells are created, if somebody's immune system is not working correctly, we can sometimes transplant somebody's marrow into them as long as it's a good match, and hopefully if it's done right, then that bone marrow will take and their immune system will fix itself. If they get it wrong, then the donated bone marrow will start attacking the recipient. That's called graft versus host disease, and it's usually fatal. Now, bone is a type of connective tissue. The primary component of bone is osseous connective tissue. And bone, because it is connective tissue, is made out of cells and an extracellular matrix. We have some different types of cells in bones. There's osteoprogenitor cells, osteoblasts, osteocytes, and osteoclasts. The osteoprogenitor cells are the bone stem cells. They're derived from mesenchyme, which is a type of fetal tissue, and they're juvenile. They haven't really committed yet to another type of cell line. They've already committed to being a bone cell, but they haven't really decided which one yet. And we find osteoprogenitor cells in the periosteum and the endosteal membranes. Osteoblasts are a type of cell that synthesizes and secretes osteoid. Osteoid is the organic part of the bone matrix, and it will later calcify. The osteoblasts, as they are producing the osteoid, are causing bones to grow. They literally kind of paint themselves into a corner, and they become trapped in the osteoid that they have secreted. At that point, they're mature, and we call them osteocytes. They're no longer really active with the secretion of osteoid, but they do some of it. The osteocytes, as I mentioned, are the mature osteoblasts that got trapped within the osteoid. They've lost their bone-forming ability, and they just kind of help take care of the bones. Osteoclasts are really interesting. They're large, they're multinucleate, meaning they've got a lot of nuclei in them, and they're a type of phagocytic cell. The osteoclasts break down bone. They dissolve it, and it's a bit complicated. As the osteoblast starts to dissolve bone, there needs to be acids to help etch away the calcium, and there also has to be enzymes to take care of the osteoid and the collagen. Because that is such a complex process, we end up with these multinucleate cells. As we look at the bone matrix, we have both organic and inorganic components. Bone has a lot of collagen in it. Remember, collagen is a very strong protein strand, and we do want our bones to be strong. So collagen gives them a lot of tensile strength. That means as you grasp two ends of the bone and try and pull it apart, it's the collagen that prevents you from doing that. The inorganic components would be salt and calcium phosphate. The salt interacts with the calcium phosphate, and we get hydroxyapatite crystals. These crystals are extremely dense, they're very, very hard, and they give bones the rigidity and their compressive strength. So if you take a bone and you try and crush it between your hands, it's the hydroxyapatite calcium crystals that are preventing that. So we need both of these in bones. We need both the collagen and the osteoid, and we need the hydroxyapatite crystals. If all we had was the collagen, then the bones would be very bendy. They wouldn't provide a lot of strength as far as compression goes, and they would start to bend pretty horribly. On the other hand, if all you have is the calcium, then the bones would be very, very hard, but they would also be very, very brittle and wouldn't be able to bend at all. Because we have both of these things, our bones have found kind of the sweet spot where they can bend a little bit, but they're also very strong. So bone formation is going to begin with secretion of the osteoid, that organic part of the matrix, and then the osteoid is going to calcify as we get the hydroxyapatite crystals being deposited. This requires quite a lot of calories, actually, a lot of vitamin D, a lot of vitamin C, and calcium and phosphate. To reabsorb bone, we're going to use those osteoclast cells. We're going to release proteolytic enzymes that are going to take care of the osteoid, the organic matrix, and then the calcium and phosphate are going to be destroyed or dissolved by hydrochloric acid. As the calcium is freed up, that and the phosphate can enter the bloodstream. So as far as physiology goes, your bones are just kind of a big calcium bank. You can make deposits and withdrawals, and you do that by making more bone or by dissolving more bone. So let's say you have too much calcium in your blood. You need to make a deposit. So you're going to go to your osteoblast cells, and you're going to take that calcium out of the blood and put it into the bones and store it for later. On the other hand, if you're low in blood calcium, then you're going to go ahead and activate those osteoclast cells. They're going to dissolve some of the bone, freeing up the calcium, which is then placed into the blood, bringing your blood levels of calcium back into homeostatic balance. There's a disease called osteitis deformans. This results from a disruption between the osteoclast and osteoblast function. It needs to be a balance between the two. Osteitis deformans is characterized by excessive bone reabsorption, followed by excessive and kind of haphazard bone deposition. We get larger osteoclast cells that reabsorb bone at a higher rate than normal. The newly deposited bone is poorly deformed, and we see this in bones of the pelvis, skull, the vertebra, the femur, and the tibia. This is going to cause the bones to be deformed, and that's going to lead to altered biomechanics and eventually pain. I've already mentioned compact bone, or cortical bone as it's known, and spongy bone. They're unique. They've got different microscopic structures and therefore different functions. Compact bone, also known as cortical bone, is made out of small cylindrical structures called osteons. An old name for them was the Haversian system. These little osteons are the basic functional and structural unit of mature, compact bone. Each osteon has a central canal, concentric lamellae, osteocytes, and cannuliculi. So here is our central canal. There's a couple pictures actually. And you can see the osteocytes are going to be in these little lagoons, these lacuna. There's tiny, tiny canals, you can see some of them here, called cannuliculi, that allow for nutrients and gases and waste products to be exchanged between the cells in the bloodstream. And then our central canal is used to route both arteries, veins, and nerve endings. As the central canal runs the length of the bone, we get little perpendicular canals called perforating or Volkmann's canals that jet out to the side, and it's just another way to run more blood vessels and more nerves throughout the entire volume of the bone. Now, when we look at an osteon, there's circumferential lamellae. So let's go back to here. You see these little rings all over the place? These are the circumferential lamellae. And then here we have a little bit of interstitial lamellae. The circumferential lamellae are little rings of bone. The interstitial lamellae are just really old osteons that have been partially eaten out. What happens is as you need to release more calcium into your blood, you're going to have some osteoclasts come into the bone, and they're going to make holes in the bone. They're going to drill little wells just kind of randomly all over the body. You don't want to do too many in one area because then that area of the bone would be abnormally weak. Instead, it's done microscopically all over the place. And then, as you need to deposit calcium, you're going to fill up those holes, and that's what causes a nice round osteon. So as this occurs again and again and again, you get these overlapping circles where the new ones are the circumferential and the older ones are the interstitial. Now this is really neat here. These lamella or layers are where we've got layers of osteoid and hydroxyapatite crystals and collagen fibers, and here they're actually showing the orientation of the collagen fibers. Between the osteons, the collagen fiber orientation is going to vary between each lamella, and that's going to give the bones an incredible amount of strength. It's like 2-ply on a tire because you've got the reinforcing fibers running in different directions with each layer, the overall structure is incredibly strong. Here again are concentric lamellae, kind of from the side, and they've removed some of them so you get kind of a, looks like a little tiered cake kind of thing. If we just took a section right through the center, you can see the lamellae over here. And if we really zoom in, you can see one of the osteocytes locked in its little lacuna and all the little cannuliculi so it can communicate to its neighbors. I've already mentioned in spongy bone, the pattern of growth where we actually have bone instead of holes are called the trabecula. It's that lattice of narrow rods and plates that we can see. The lamella inside of spongy bone is parallel. The cannuliculi radiate out from the lacuna. So here is some of our trabecula. We've cut one right here so you can see all these parallel lamella. Now let's step back a little bit and talk about cartilage again for a few minutes. We have to do that because the way we make long bones is we're going to make a hyaline cartilage model of the bone, and then we're going to replace that with osseous tissue. Cartilage is a type of connective tissue. We have our living cells in a non-living matrix. Cartilage is resilient, it's flexible, and specifically for these long bones, we're going to use hyaline cartilage. It's hard, it's dense, it's a really good shock absorber, but it is avascular and does not contain nerve endings. Chondroblasts would be the cells that produce cartilage. Chondrocytes would be the mature cells that are encased within the matrix. Hopefully you see a common thread here. The perichondrium would be the membrane surrounding the cartilage. So if we look and compare bone connective tissue and hyaline cartilage connective tissue, we can see the names are very similar. Cells that form matrix are called blasts. The mature cells are called cytes. The cells, when they're mature, end up kind of painting themselves into a corner and they're locked into the lacuna. Bone has calcium, cartilage does not. Bone has a huge blood supply, hyaline cartilage does not. So as cartilage grows, it can do so in two different ways. The first way is called interstitial cartilaginous growth, and the second way is called appositional cartilaginous growth. An easy way to think about this is the interstitial cartilaginous growth comes from within. So if you took and made some cake batter, poured it into a pan, popped it into the oven, the whole thing would rise. You don't get any new layers to your cake, but the whole thing is going to get thicker. So that would be a type of interstitial growth. Appositional growth, on the other hand, is adding a layer to the already existing surface of cartilage. So in this case, you take your cake out and you put frosting on top. Now the cake itself really didn't change in size, but the entire thickness increased a little bit because we put a bunch of frosting on there. Now let's say the frosting dries out and gets all hard and nasty, and you could put another layer of frosting on top of that. So the entire cake is going to get higher and higher and higher by adding layers to the outside. So that is appositional cartilaginous growth. With interstitial growth, the chondrocytes inside of the lacuna are stimulated. They start to divide. We get two cells, chondroblasts, and they're stuck in a single lacunae. They're going to secrete new material, and that pushes each other apart, and each is now called a chondrocyte. So that's our interstitial cartilaginous growth. So here's our single cell in a lacuna. It undergoes mitosis. We now have two of them. They're continuing to secrete the cartilaginous material, and that causes them to be pushed apart. Appositional growth is where we have our stem cells at the edge of the perichondrium that are going to start to divide, and that's going to give us a new layer on the outside of our cartilage. So here we've got some of the older cartilage. We've got new cartilage up here with undifferentiated stem cells. They're dividing, turning into chondroblasts, secreting matrix, and kind of pushing themselves apart. But the ones underneath in that older cartilage are not doing that. They're not participating in that process. And so only this kind of pinkish layer here on the outside is going to get thicker. And the older cartilage layer is going to start moving up as those cells stop dividing, but the new cells on top are going to keep on moving. So during early embryonic development, the interstitial and appositional cartilaginous growth occur at the same time. They occur quite rapidly. As cartilage matures, the interstitial cartilaginous growth starts to decline pretty rapidly, except for a few areas. The cartilage becomes semi-rigid, and the future growth is primarily appositional. After cartilage is fully mature, new growth stops, although you can still repair yourself after an injury. Now, ossification, or osteogenesis as it's known, is the development of bone connective tissue. This begins in the embryo. By about week 8 through 12 of embryonic development, the skeleton is starting to form. We've done intramembranous ossification and endochondral ossification. So just as we had two types of cartilaginous growth, being interstitial and appositional, we have two types of skeletal growth, being intramembranous and endochondral. Intra means within or between, so intramembranous ossification is between two membranes, and endochondral ossification, endo is from within, and then chondro, of course, would be cartilage, so this is growth from within the existing cartilage. So intramembranous ossification, as I mentioned, is bone growth within a membrane. This is going to produce flat bones of the skull, some of the facial bones, the mandible, and this begins when mesenchymal tissue thickens with capillaries. We get something called an ossification center within the thickened region of the mesenchyme. Some of the cells will differentiate and become osteoprogenitor cells, and then some of those will then become osteoblasts and secrete osteoid. The osteoid will undergo calcification, and as we deposit those hydroxyapatite crystals into there, the osteoblasts will become trapped and become osteocytes. At first, the bone is what we call woven, and the periosteum is going to form around there, and the bony tissue is actually pretty immature and poorly organized. And then as we start to develop more and more of it, we start to get lamellae, or secondary bone, that's going to replace some of that woven bone. We're going to have our compact and spongy bone form from the trabecula, and we get a typical structure of, say, like a flat cranial bone. So here is some of our osteoprogenitor cells that have chosen to become osteoblasts, and this area is an ossification center. As these cells secrete osteoid, some of them are going to get trapped within that calcifying material, while the other cells on the outside are going to continue to divide and secrete more osteoid, and so the entire ossification center is going to get larger and larger. Eventually we're going to have woven bone with surrounding periosteum, and then that's going to be in turn replaced with lamellar bone. We're going to have the compact layer and then our spongy layer. Endochondral ossification is going to begin with that hyaline cartilage model. Most of the bones of the skeleton, including the bones of the limbs, the pelvis, the vertebra, and the ends of the clavicles, all undergo what's called endochondral ossification. Step one is going to be making a hyaline cartilage model, and this is done during fetal development during weeks 8 to 12. And then we're going to calcify that cartilage. The first thing that happens is we're going to get a bony collar, periosteal collar, around what's going to be the diaphysis. The matrix of the cartilage is then going to calcify, and as it does so, the chondrocytes are going to die. Blood vessels are going to grow toward the cartilage to deliver more nutrients, and osteoblasts are going to continue to develop and secrete the osteoid. That periosteal bone collar will then begin to expand and go up and down the diaphyseal shaft. Small periosteal buds are going to extend from the periosteum into the cartilaginous shaft. And this is our growth of capillaries and osteoblasts. They're kind of pushing into that cartilaginous material. Our osteoblasts are going to produce osteoid on that calcified cartilaginous template, and this is called a primary ossification center. It's the first major center of bone development, and most of these are formed by week 12. So that's pretty early in fetal development. We're already getting the beginnings of our skeleton at about 3 months. And then secondary centers of ossification are going to form in the epiphyses. Each epiphysis is going to be its own secondary center of ossification and have its own blood supply. Now, the interesting thing is, as the osteoblasts are secreting osteoid on the outside of the diaphysis, some of the osteoclasts will start dissolving bone on the inside of our diaphysis. Remember, the inside is where we're going to have that medullary cavity, and that's how it gets there. Those osteoclast cells start to dissolve some of that bone on the inside. Well, this continues. We're going to keep layering more bone on the outside, and we're going to dissolve more bone on the inside. And so the cortical thickness of our diaphysis is not going to change very much. It is going to get a little bit thicker, but the entire diameter of the diaphyseal shaft will continue to increase. As we continue to ossify our cartilaginous model, we're going to do so in all places of that long bone except the articular cartilage and at the epiphyseal plates. The epiphyseal plates are going to stay open. They're going to remain as cartilage up until late childhood, early adulthood. So here's a 10-week-old fetus with our hyaline cartilage model with a little bit of perichondrium running around it. And then we're going to start to encase it in that bony periosteal collar. Inside, you can already see that we're deteriorating some of the cartilaginous matrix and replace it with a little bit of osseous tissue. We've run a blood vessel into this primary center of ossification. And then eventually, we're going to run blood vessels into our epiphyses for our secondary centers of ossification. Separating the diaphysis and epiphysis, we have the metaphyseal region where we have our epiphyseal plates. Now you notice these are still cartilaginous and they're going to remain so through childhood. As the diaphysis becomes calcified, it becomes much stronger, and as the epiphyses calcify, the same thing happens there, but you'll notice that the epiphyseal plates are still present. Inside the epiphyseal plate, it's still hyaline cartilage. We're going to be doing very rapid interstitial cartilaginous growth. So this is, remember, like our cake batter that we pop in the oven. It's going to get thicker and thicker, and this is what happens to our epiphyseal plate. And as they get thicker and thicker, the bones are going to get longer and longer. Now, at the same time this is happening, toward the edges of our epiphyseal plate, we're going to be ossifying that older cartilaginous tissue, and that's our endochondral ossification. So as the bone gets longer and longer, it's because the epiphyseal plates are getting thicker and thicker, but at the same time, the epiphyseal plates are also getting smaller because they're turning into bone. And these two things balance each other out, and so as a child gets longer and longer bones, the epiphyseal plate really doesn't change thickness very much, but the bone continues to get longer. Now, at the end of childhood, what happens is that the wavefronts of endochondral ossification are still running quite rapidly, whereas the interstitial cartilaginous growth really starts to slow down. What this means is that the waves of endochondral ossification are going to pass our interstitial cartilaginous growth, and the two wavefronts of our osseous formation are going to run together, and at that point, there's no more cartilage. If there's no cartilage, there's no more interstitial cartilaginous growth, and the bones have stopped growing lengthwise. So bone continues to grow and remodel during childhood, and it continues to remodel during adulthood. So as different stresses are placed on the bones, they can change. They can change in diameter and in thickness, which is our appositional cartilaginous growth, but they only get longer during childhood with our interstitial cartilaginous growth. So let's look at our interstitial cartilaginous growth a little bit closer here. We've got 5 zones of the epiphyseal plate. We have a zone of resting cartilage near the epiphysis. We've got small chondrocytes, They help to secure the epiphysis to the epiphyseal plate. We have a zone of proliferating cartilage. Proliferation is where cells are going to undergo rapid mitosis. And then the zone of hypertrophic cartilage is where the cells don't do mitosis, but they will grow in size and become larger. Then we have a zone of calcified cartilage, which is 2 to 3 layers of chondrocytes. And this is where we're destroying the chondrocytes and replacing them with calcified tissue. And then finally, the zone of ossification, where we're breaking down the lacuna, typically in columns, and then the space is invaded by capillaries, osteoprogenitor cells, and we're replacing that cartilaginous tissue with our new bone matrix, that osteoid, which is then deposited on our calcified cartilage. So the zone 1 of our resting cartilage, this is near the epiphysis. Zone 2 is it's proliferating, 3 is it's hypertrophic, 4 is it's calcified, and 5 is the zone of ossification. Now zones 2 and 3 are where most of the growth and length is going to occur. Remember, zone 2 was the proliferating area, and zone 3 was the hypertrophic area. As we get more cells and as those cells get bigger, they're going to push the two ends of our bone apart. Eventually, as those wavefronts of ossification overrun the area of cartilage and there's no more cartilage left, then you're left with a solid plate of osseous tissue called an epiphyseal line. Here's a lovely x-ray of a hand. This is a child. Here we have the epiphyses of the radius and the ulna, and you can see the epiphyseal plate here is still open. Now these are not separate bones. This is all one bone, and this area is connected with hyaline cartilage. If you took this bone out and looked at it with the naked eye, it would all look like one big bone. But we've got this open area here where we can do our interstitial cartilaginous growth and our endochondral ossification to cause the bone to get longer and longer. Now we don't see this in the carpal bones because these are short bones. They develop using only appositional cartilaginous growth and intramembranous ossification. So they do not have an epiphysis, a diaphysis, or an epiphyseal plate. But as we move on into the palm where we have the metacarpals, again we can see our epiphyseal plates and into the phalanges and so on. As forensic scientists look at skeletons, they can determine age through a variety of factors, but one of them is just looking at those growth plates. If the growth plate is still open, then it's clearly a child. The growth plates don't close suddenly. They close in a progressive fashion. And so by looking at which ones are closed, which ones are open, and how far the closure is on some of them, it gives us a much better idea of how old that child is. Females typically reach skeletal maturity a year or two before males. Let's look again at that appositional growth. I mentioned this before, but I'm going to talk about it in a little more detail here. We've got our periosteum on the outside of the diaphysis and our endosteum on the inside of the medullary cavity. The osteoclasts on the inside are going to be reabsorbing bone, whereas the osteoblasts in the periosteum are going to be depositing more bone, and so our cortical thickness is going to get a little bit bigger, but the diameter of the diaphysis is going to get significantly bigger. So here's our compact bone, our periosteum. This is the area where we're going to be laying down new bone, and inside the medullary cavity with our endosteum, we're going to be reabsorbing bone with the osteoclasts. As we continue to lay down more and more and more layers on the outside, it's going to get thicker, but at the same time, we're tearing down layers on the inside. And so the overall thickness really hasn't changed a lot, but the diameter has increased dramatically. Now, A means without. Chondro, of course, is cartilage, and then plasia, remember, is meiosis. So achondroplasia are cells that are not going to divide, so they're not going to grow. So achondroplastic dwarfism is a disease where we're not doing hyaline cartilaginous growth. Because we use hyaline cartilage specifically with our endochondral ossification of the long bones, these long bones don't get very long. They remain fairly short. So achondroplastic dwarfs tend to have very short, long bones, but their short, flat, and irregular bones are all of normal size because we're using intramembranous ossification and the oppositional cartilaginous growth. Now, bones will change throughout adulthood. They will remodel. It occurs at the periosteal and endosteal surfaces, and it kind of depends on the bone and where you're at on the bone, how often or how rapidly that occurs. For example, the distal part of the femur is replaced about every 4 to 6 months, whereas the diaphysis isn't completely replaced over your entire lifetime. We figure about 20% of a skeleton is replaced every year. It depends on the coordination between osteoblasts, osteocyte, and osteoclasts. As I mentioned, it's highly dependent on mechanical stress, but also hormones, which are chemical messengers. As you engage in weight-bearing exercise and movement, that stress is detected by the osteocytes and the osteoblasts, and it's going to cause an increase in the synthesis of osteoid. In other words, your bones are going to get a little bit thicker, causing them to become a little bit stronger. So increased bone mass comes from weight-bearing exercises. If you remove that mechanical stress, then you're going to decrease bone mass. For example, astronauts who go into orbit, they no longer have gravity sucking down at them all the time. We've removed that mechanical stress, and so they're going to start removing a lot of bone mass. We'll have demineralization of the bone. We see the same thing in patients who are stuck in bed or who can't move or are paralyzed. We see a lot of demineralization of those bones. This is really kind of cool. We can take our body, and our body responds to different stresses in the most appropriate fashion. If you go to the gym and you lift a lot of weights, blast your pecs a bit, your bones are going to get stronger along with your muscles getting bigger. If you sit on the couch all the time and eat bonbons, well, obviously you don't need strong bones, and so you're going to demineralize. So that response to mechanical stress is called Wolff's Law. Now, bone growth is influenced by hormones. Hormones, as I mentioned, are chemical messengers. They're released into the bloodstream and they go all over the place, but tend to affect certain types of cells more specifically. Growth hormone is the most critical hormone for bone growth. It's also known as somatotropin. It's produced by a gland in the brain called the pituitary gland. Thyroid hormone is also required for bone growth, although it is secondary. So here's some great examples here. This man here is Robert Wadlow. When Robert died, he was 8 feet 11 and a bit inches tall. He was really trying to go for 9 feet. He suffered from something called pituitary gigantism. Giant is actually a medical diagnosis. Remember, the long bones are going to grow most during childhood. That's because the epiphyseal plates are still open and have hyaline cartilage. Since growth hormone is the primary determining factor for how long those bones are going to grow, if your pituitary is going a little nuts and producing way too much growth hormone, then those long bones are going to get very long indeed. That's why Robert was such a very tall man. The problem with this is that even though the bones are getting longer, they're not going to get that much thicker. And so this causes a lot of stress on the bones, which translates to a lot of pain. Nearly every single patient with gigantism ends up in a wheelchair fairly early in life because it's just too painful to stand up. Over here, we have some pituitary dwarves. So these gentlemen in The Wizard of Oz, and their pituitary gland didn't make enough growth hormone. And so they remain fairly short. Now, they're fairly normally proportioned. Their arms and legs look to be about normal length for their body size. And so this is pretty typical with pituitary dwarfism. We get a fairly normal body shape. Down here at the bottom, we have what is called achondroplastic dwarfism. Now remember, with the achondroplastic dwarfism, there's a problem producing hyaline cartilage, and because of that, the long bones are not going to get very long. They can still do intramembranous growth, which is why the flat bones and the irregular and the short bones are all normal size. So if you look at these two individuals here, we can assume they're brothers. Their heads are the same size, their torsos are the same size, but the individual on the right has very short, long bones. And then, of course, over here we have mini-me. Other hormones that influence bone growth would be sex hormones like estrogen and testosterone. These come into play during puberty when they're secreted in large amounts and cause a tremendous acceleration in bone growth. Glucocorticoids are a type of steroid hormone. If used in high amounts, this actually increases bone loss. A lot of times athletes will injure themselves. Glucocorticoids are used as an anti-inflammatory, but the dosages are limited because it will cause significant bone loss. Serotonin is a neurotransmitter and hormone. Most of our bones have serotonin receptors, and serotonin helps regulate bone remodeling. I want to talk about calcium regulation for a few minutes. Calcium regulation is critical in the blood. So this is an idea of homeostasis here that it's important for you to understand. Homeostasis tends to be very critical in certain areas and a lot less critical in others if we're talking about the same exact thing. So in this case, calcium. So blood levels of calcium are absolutely critical to staying alive moment to moment. Skeletal levels of calcium, on the other hand, are not that big of a deal, at least not moment to moment. They will affect your life long term, but not like the calcium in the blood will. So if you had to pick one of those things to get a little wonky to save the other, then you're definitely going to be stealing calcium from the bones to make sure that your blood levels are correct. We use calcium, or the reason calcium is so critical is because we use it for muscular contraction. And by the way, your heart is a big muscle. We use it for exocytosis of molecules from cells, including neurons and neurotransmitters. So your brain is going to use a lot of calcium. And we also use it for blood clotting. Now there's two hormones that help regulate calcium in the blood: calcitriol and parathyroid hormone. So UV light is going to convert 7-dehydrocholesterol into vitamin D3, also known as cholecalciferol. This is released into the blood, and vitamin D3 helps us to absorb calcium from our diet. Calcitriol is the active form of vitamin D3. The cholecalciferol in the skin is going to be released into the blood, travel to the liver where it's converted to calcidiol, and then calcidiol is going to be converted in the kidneys to calcitriol, which is the active form of vitamin D3. Calciferol in the skin, calcidiol in the liver, and then calcitriol from the kidney. Parathyroid hormone is a hormone that allows us to pull calcium out of our bones. It's going to accelerate the conversion of calcidiol to calcitriol by the kidneys. It's going to cause more absorption of calcium from the intestines. It's also going to majorly affect the osteoclast cells to release more calcium from the bones. Now, rickets is a disease that's a deficiency of vitamin D. The definition of a vitamin is a nutritious substance that if you lack enough of it, it will cause a specific disease process. For example, if you don't have enough vitamin D, you get rickets. If you don't have enough vitamin C, you get a disease called scurvy. If you don't have enough vitamin B12, you get a disease called pernicious anemia, and so on. That's the literal definition of a vitamin. So back to vitamin D and rickets. If for some reason you can't absorb calcium because you can't make vitamin D, or you're deficient in calcium in your diet, then your bones will continue to grow, but not very well, and they're going to be lacking a lot of calcium. So they still have the collagen for tensile strength, but they don't have the compressive strength. Remember how I mentioned the bones can become pretty bendy? So you can see this little guy here has rickets. look at his left leg, you'll notice that that his feet are pointing forward here. He's massively bow-legged because his tibia and his femur are both bent because of lack of calcium. So that is just the weight of gravity pulling down on his little bendy bones and causing them to bend permanently. Now, another hormone is called calcitonin. Calcitonin basically does the exact opposite of parathyroid hormone. It turns out in humans, calcitonin really isn't that critical. Parathyroid hormone, on the other hand, is extremely critical. Humans can get along without calcitonin, but you're going to die pretty rapidly without that parathyroid hormone. Since calcitonin does the opposite, it's going to inhibit our osteoclast cells and activate the osteoblast cells, and therefore decrease the amount of calcium in the blood. As we get older, our bone is affected in two different ways. We have a reduced rate of protein synthesis by osteoblasts, so we've got less collagen. The bones are brittle and more susceptible to fracture. And then we can also have a loss of calcium and other minerals. The bones can become thinner and weaker, and this is called osteopenia. Osteopenia is poverty in Latin. So osteopenia occurs slightly in all people with age. At about age 35 to 40, the osteoblast activity declines, osteoclastic activity continues at its previous level, and so we start getting larger holes in the bone, and the vertebra, the jaw bones, and the epiphyses of long bones are going to lose a lot of mass. Women tend to lose a lot more of their skeletal mass every decade than men do. So in the background here, you can see kind of the progressive effects of something called osteoporosis. Porous is to have holes in it, and so osteoporosis is having a lot of holes in your bone. Osteoporosis, we have enough of a reduction in bone mass that the bones are compromised as far as strength goes. This occurs in a significant portion of older women and a smaller portion of older men. And a part of that is because we have reduced hormone production with age. Vitamin D, growth hormone, estrogen, and testosterone all are going to decrease, and this is going to contribute to the loss of bone mass. Pretty quickly here, I want to go over some fractures in bones. Now, any type of break is a fracture. Doesn't matter how extensive the break is. Break and fracture mean the exact same thing. Stress fractures are thin breaks caused by repetitive physical activity. So, for example, runners will often get stress fractures in the lower limbs. A simple fracture is one where the bone is broken but not poking through the skin. A compound fracture is where at least part of the broken bone is poking through the skin. And then a pathologic fracture only occurs in weakened bone. If you get out of bed in the morning, take a step, and break your leg, not by tripping, just by standing up, then that's a pathologic fracture. So you can see there's a whole bunch of different types of fractures. There's avulsion fractures, Colles, comminuted, complete, compound, compression, etc. You should know some of these. Avulsion is to pull off of. So a lot of times a toe or a finger will have an avulsion fracture. A comminuted fracture specifically means the bone is shattered. Typically your bone is one piece. If you have two pieces, then it's a fracture. If you have more than two pieces, it's a comminuted fracture. Compound, as I mentioned, was an open fracture where it's protruding through the skin. This is going to wildly increase the risk of infection. Simple fractures are much better, even if they're comminuted simple fractures, because even though the bone is shattered, the chance of infection is way down. A green stick fracture happens in long, thin bones, especially in children. It's a partial break from when the bone is bent extremely. Hairline fractures are very thin fractures that go through the bone. A lot of times these are very hard to see on X-ray. I mentioned a pathologic fracture, a simple fracture. Spiral fracture is what it sounds like, where the fracture spirals along part of a long bone. And then a transverse fracture is where it goes straight across. As fractures heal, they heal fairly quickly when you consider the size and extreme density of bone. They heal very shockingly fast, and that's because they have a massive blood supply. Simple fractures completely heal in 2 to 3 months. After 6 to 8 weeks, you're actually ready to take the cast off, although you shouldn't quite go nuts on it just yet. Compound fractures are going to take longer to heal, and healing slows down with age or other comorbidities or diseases that you have at the same time. And if the fracture is bad, it might require surgical intervention to line everything back up to heal correctly. The first thing that happens is you're going to get a fracture hematoma. Because of all the blood vessels running through the bone, as soon as you break it, you're going to damage those blood vessels. You're going to have quite a lot of bleeding going on. And that's all. That blood is going to be collected within the periosteum. So that's our fracture hematoma. And then a fibrocartilaginous callus will form. This will be replaced by a hard or bony callus that will continue to grow and thicken. And then finally, we're going to have to do some bone remodeling to bring it back up to normal strength. So here is our fracture hematoma. We've got our periosteum here on the outside, and most of the blood you can see has been contained within it. That's going to turn into our fibrocartilaginous or soft callus. And then that soft callus is going to become a hard or bony callus. And at this point, a lot of times the cast will come off, but you still have to do some bone remodeling. You want to see what happens if you exercise on a hard callus before the bone is fully remodeled. Go ahead and Google Kevin Weir. He was a basketball player, and as he went up for a fairly normal jump, he came down on a previous injury that hadn't completely healed and snapped his shin, did a nice compound transverse fracture of the tibia right across a bony callus that he'd had there previously.